Kia ora koutou, ko Jacob Tokuinoa. I'm the CEO of Auckland Golf. Thank you for joining us. We've got a wonderful opportunity here with Dr. John Carter to present the work that he's doing with Molecheck and then for us to present the partnership that we have. This has been going for a year now. Looking forward to continuing it in the future. And we're working out between ourselves and Molecheck how best to communicate the importance of skin checks and skin care to golf members, and especially the golf members of Auckland Golf. That's it from me. I'll just sit back and mute myself. And Dr. John, you can start us off and take it from there.
I'll just share my screen, folks. Here we go. Right, can you all see that? Yeah. So thanks for the introduction, Jacob. My name's John. I work as a GP in Royal Oak, and also I do a few sessions at Molecheck along with some other GPs who have had extra qualifications in skin cancer medicine and in treating skin cancers. So it's obviously a passion of ours, and it's a real pleasure to be here this evening just to talk to you about what we do and a little bit about skin cancer so that you can have a better understanding. I'm a tennis player rather than a golfer, but I do have quite a bit of interaction with golfers in my job, obviously from sun exposure and skin cancers. I must say they're all very pleasant people to deal with. I think a walk in the park with your mates and perhaps the humility that golf teaches you probably is a good lesson in life. And so it's always a pleasure to deal with people from the golfing community. So we're going to talk a bit about skin cancer, and we'll start with perhaps a few numbers without getting too boring, hopefully. But we have a big problem in New Zealand in that we have 67,000 cases of skin cancer a year, which is about 4 times the rate of the US and the UK, and melanoma in particular, which is the nastiest skin cancer we'll talk a bit about later on, is the 3rd most common cancer after breast cancer and prostate cancer in New Zealand. We have about 4,000 a year, and we have more people dying from melanoma than we do on the roads, about 1 person a day. It's about 350 a year. It's a common cancer in young people, even though cancer is uncommon in that group. Melanoma is certainly represented. So you can see we have a problem in New Zealand, and you might say, well, look, why aren't we doing a bit more about screening for melanoma in particular, given that we have breast cancer screening, we have bowel cancer screening, we have lung cancer screening, cervical screening. But the problem is that skin cancer doesn't always affect all members of the population equally. So we're trying to track down those people that might be at higher risk, and perhaps warn them and give them an opportunity to be more aware of what skin cancer is and how it might affect them. So basically about 2 in 3 Kiwis will be diagnosed with skin cancer by the age of 70. When you think about the fact we're not all fair skin, that does mean that those with fair skin who get most of the skin cancers are particularly at high risk. In terms of the types of skin cancer, melanoma, which everyone talks about, is actually quite a rare skin cancer, only about 3% when you look at the other skin cancers that aren't melanomas, such as basal cell or BCC and squamous cell or SCC. BCC is probably the most common cancer known to human beings, but no one ever dies from it. It's not a cancer that spreads or that is in any way lethal. It just forms a sore that grows slowly over time, and which is unpleasant. Squamous cell carcinoma, about 30% of skin cancers. Sometimes it can be lethal. But if you look at the mortality on the right-hand side, you can see that the one that is the killer is melanoma, particularly in men, and particularly as we get older. Possibly for men, it's because most of their melanomas seem to occur on their back, and so they may not always be aware until it's got away on them. It's thicker and deeper. And so it's always a good plug to have a loved one looking at your back from time to time, just looking for an ugly duckling or something that sort of stands out from the crowd that's changing and different. And one of the big factors, of course, with our skin cancer risk in New Zealand and particularly in this part of the world is is UV or ultraviolet radiation. And there's lots of reasons why that's a problem. Firstly, we have very little air pollution in New Zealand. And air pollution, of course, helps to filter out the UV rays. Secondly, we've got a pretty outdoor sort of lifestyle. So we tend to be doing things outside more and getting sun exposure. Thirdly, in New Zealand summer, the planet's a bit closer to the sun than it is in the Northern Hemisphere summer. So we tend to have a bit more UV exposure than perhaps they would up in northern latitudes when we're outside in the summer doing things. And of course, there's this issue of ozone. Every year in the springtime, there's a big hole in the ozone layer, which is like the sunblock for the world, not over New Zealand, but over the South Pole. And then as that dissipates, it spreads areas of ozone-depleted air over the surrounding countries like New Zealand. So we do have a lower level of ozone, or if you like, the sunblock. So when you put that together, we've got an outdoor lifestyle with more UV light. And of course, the other issue is that if we were to put a map of New Zealand and flip around into the Northern Hemisphere, would be in the similar latitude to southern Spain, Gibraltar, and Northern Africa. And if you think about the natural skin colours from those parts of the world, they're much more olive-skinned and therefore have much more natural sunblock than us fair-skinned people that come from the likes of Scotland and Ireland and England. So we've got people that shouldn't be here, and we've got problems with too much UV light exposure, which really, I guess, leads to this problem that we have with skin cancer in New Zealand. So we've talked a bit about the fair skin as a risk factor, and of course sunburn. Sunbeds deliver a very large dose of ultraviolet light, much more than the sun does, and they're a problem. And of course, they're not so much used now. In fact, they've been banned in some countries. But obviously, historically, people used sunbeds back in the 80s and the 90s. People that have got lots of moles, probably more than 60 moles, or certainly if you've got a number of unusual-looking moles, are at higher risk for melanoma. If you've had a previous skin cancer, no matter what it is, or if there's a family history of skin cancer, that's another risk factor. If you take medications to suppress your immune system, many people are these days for various conditions, that increases your skin cancer risk. Not so much melanoma, but certainly BCCs and SCCs. There's a relatively rare condition called Parkinson's disease, which affects people's ability to move well. And that's linked with the same protein that's also linked with melanoma. So people with Parkinson's have a slightly higher risk of melanoma. And similarly, those with melanoma have a slightly higher risk of Parkinson's disease. And of course, the other risk factor is getting older for lots of reasons. I guess it's an accumulative sun exposure over the years, and also potentially that the immune cells in the skin aren't quite as effective as they probably were when you were a bit younger. Just a little touch base on sunbeds. I mean, they cause all forms of skin cancer. Luckily, in New Zealand, we have at least got some way towards protecting people by banning it for those under the age of 18, because really it's those people under the age of 18 that really do suffer the most in terms of damage to their DNA and all the mutations that can lead to melanomas later in life. But they're not totally banned, so you can still have a sunbed if you wanted to, but they're just not well regulated in New Zealand. Let's have a look at a few skin cancers, the sort of things that we would see in our day-to-day life at Molecheck. The most common skin cancer, as I said before, is a basal cell carcinoma, or a BCC. And like I said, they're not fatal, but they just tend to cause enlarging lesions that eventually cause sores and ulceration. They're commonly seen around the face, where the skin's a bit oilier, so around the nose in particular, which is not an easy place to operate on. So it's quite nice to always find these things when they're small and deal with them before they're a major problem. They'll often present as a little pink lumpy patch or a scar. They can often bleed, get a bit scabby and crusty, and they just grow slowly over time. You can see on this chap's nose, he's got a BCC there. Here's another example of a BCC on someone's nose. You see it's sort of a raised, pearly, a little lump with some blood vessels on the surface. It'd be nice if this had been picked up a little bit earlier, for the sake of the cosmetic outcome for this person, because obviously he's going to have a rather large operation to clear that out with a margin and without causing too much damage to the surrounding structures. Here's another example of a basal cell carcinoma, a bit more subtle. It looks like a little scar on the side of someone's nose there. Now here's someone's face. I'm not sure whether you can spot the BCC. It's not that obvious. This one looks a bit more like a pale white scar, but with the aid of a little light we use called a dermatoscope, you can see various clues. And here we have the BCC sitting here on this person's cheek. And unfortunately, again, because you've got to take a bit of normal skin around the outside, it's a rather large hole that's left, and the cosmetic outcome isn't so good. Even in the best of hands, you can have scarring, and so it's always nice to find these things when they're early. Here's another example of a BCC. This, in fact, was treated by the patient's GP with steroid creams because they thought it was dermatitis, but it didn't seem to go away. When the patient came to us, we took a biopsy and diagnosed it as a BCC and treated it with a cream. And this is sort of a series of images showing the response to that cream in terms of how it enhances the body's immune system to actually get rid of the cancer cells without having to cut it out. So for some BCCs that are very superficial, it doesn't always require an operation. The second form of skin cancer, the squamous cell carcinoma, these ones can be a bit more aggressive than the BCCs, not quite so common, like I said, 30%, but they will often grow quite quickly, and they can be quite tender and sore and look a bit angry. And sometimes they can spread around the body, and in very rare cases, especially on the scalp and the head and the ears, they can actually be fatal. This is a picture of someone's leg with a squamous cell. You can see it looks like a little kind of crusty, sore little lump there, and that requires surgical excision. And here's one on someone's ear. Again, it grew fairly quickly, and it was quite tender and painful. But the sooner you get onto those, the sooner you can get them removed with less chance of it spreading around and less of a scar. So I guess the underlying message here is don't hesitate when you see something growing like this to get it checked out. Here's another example of a squamous cell which had been left a bit longer than it should have been, and obviously led to a slightly more complicated surgical treatment. Okay, so the third skin cancer I mentioned before, melanoma, which is the one that we really take very seriously because it can be fatal. As I said, we can see people dying with these. Typically will present as a mole. It can just look like a dark spot, but not always. They can be pink and not pigmented. And they don't just happen where there's sun. You can get them in all sorts of unusual places, such as the soles of your feet. Even inside your eyes. About 12 New Zealanders a year will get a melanoma diagnosed inside their eyes. So I always advise patients when they come for a skin check to get their eyes looked at every couple of years as well, because we can't look inside their eyes with our equipment, but optometrists are very good at spotting these sort of things. They can be slow growing and they can be rapidly growing as well. And obviously, here's someone who's recently had a melanoma, another royal family member with another cancer. This is a picture of a melanoma on someone's tummy. And I guess you could say that's pretty easy to spot. It's obviously been there for a long time and probably has been ignored. And by the time that was removed, it was about 2.5 millimeters thick. And what that really means that because it's invaded deep into the skin, there's a good chance that it could have spread around the body into lymph glands or lungs or other tissues. And so it's a shame that that was picked up so late. One of the comments we always say at Molecheck is that early detection saves lives. Here's something that's a bit more early on, but you can see this ugly duckling type lesion, this thing that stands out. And so when you're checking your spouse's back, this is the sort of thing you're looking for, something that just looks different, doesn't quite fit in, it's changing, it's growing quite rapidly. And when we look at it through the dermatoscope, which is the little light we use to look under the skin and magnify it, we can see that this looks a bit like a storm cloud. It's what we call a chaotic lesion. It's not symmetrical or balanced. There's lots of different colors and structures, lacks any kind of harmony. And so that's the sort of thing that we can diagnose pretty confidently with a dermatoscope. Here's some more pictures with dermatoscopy. Again, this is on someone's back. The lesion just below the right shoulder blade, the rather large one. And when you look with the dermatoscope, you can see all sorts of different colors. It isn't just the one plain tan color. It's got about 2 or 3 colors. It's got sort of dark brown and blacks and pinks and almost a bit of a purpley color as well. Again, so that was another melanoma in a 45-year-old man. So he had to go and have that removed and some lymph nodes tested. Another example of how the back can catch people out a bit. I guess this just speaks to the fact that melanomas can also just fit in with the other spots and look fairly innocuous. The lesion you can see circled there was a very early melanoma in situ, which means that the melanoma cells were just sitting on the surface of the skin rather than actually invading. But again, that was picked up with dermatoscopy and was treated just with a simple excision, and that was all that's required. I'm not sure where you start on a back like this, but with the dermatoscope, it helps us an awful lot in terms of almost a superpower to better look through the skin and see the lesion. So it's anyone's guess as to where the melanoma is on this lady, but there it is there with the circle around it. Again, it was an early one that was easily treated. Here's another example. It's pretty hard to spot with the naked eye where the melanoma is on this person's back. But the lesion was actually the one that was less dark. It was a slightly pink one, but you can, if you use your imagination, you can see little lines poking out or growing out sideways like little spiky bits. There's another form of melanoma that occurs on the face, which is quite common, called lentigo maligna. And we see quite a bit of that in New Zealand. And that reflects really kind of chronic or ongoing accumulative sun damage. And you get these sort of little darky brown patches that slowly grow. This is what we see with the dermatoscope. And if you look at the top part of it, you can see there's quite a little sort of bits of dark pigment and lines in there which give us clues as to the fact that this is an early melanoma. Here's another example on someone's cheek. This patient actually came in for another lesion and surprisingly hadn't been too concerned about this. But it had been left for a long time and it had actually become quite invasive to the point where it was quite thick and she had to have her whole cheek removed. Not a common thing for us to see, but it's sad when these things do come along when people haven't been on top of what's going on. As I mentioned before, not all melanomas actually are pigmented. This one just presents as a little pink lump, but it's changed and it's grown quickly. And so it's called a hypo or an amelanolic melanoma, and they can be quite aggressive because they do grow quickly. As this person had to have that lesion removed, this is the result of that. It's quite a big scar because you need to take quite a large margin and have to have some lymph glands removed to be tested as well. But this person's alive and well. They've had a good outcome. They've had their melanoma cured. If it had been left any longer, it could have been a very different story. Another example of a melanoma without any pigment. Again, this one was just an in situ lesion, or one that was just sitting on the surface. So it was a good pickup to be able to be found early and treated without too much drama. Here's some more. This is another little subtle spot on someone's leg. There's not much to see on the top left corner with the naked eye. There's an arrow beside the little lesion there. But if you look at these photographs on the bottom of the image there, again, you can see how the pigment isn't evenly spread. There's a lot of darkness and thickened pigment at the bottom southeast corner compared to the rest of the lesion. And again, this was a very early melanoma that was picked up, and the patient's absolutely fine. They've done very well. This person spotted a little tiny mark on their arm which had changed recently. So they presented to us, and this is what it looks like under the dermatoscope. You can see these little, we call them pseudopods, little lumpy kind of bumps on stalks poking out the outside of the lesion, which is another feature of melanoma. And again, this person's done very well because it was picked up early on. And here's another melanoma in a 32-year-old lady that had grown pretty quickly. And and was quite thick by the time it would have been diagnosed. Again, if you look at the pictures down the bottom, you can see all the different colours in there, which help to give us a clue that this is not just a nice, harmonious, balanced lesion, but a chaotic mess, which is how cancer cells will grow. This is the sole of someone's foot. They actually came along because they were worried about a spot on their face. When we see people, we do a full body skin check. And places like the sole of the feet can often be a bit of a trap because no one really looks at the soles of their feet. And so if a melanoma on the foot is there, it can often present again quite late, and hence have a higher mortality rate for people because they've had plenty of time to grow and to spread around the body. If we look at the dermatoscopy of this lesion, you can again see that it lacks any kind of harmony or balance. The right-hand side, the pigment's all kind of filled in compared to the left-hand side. And there are other little features there that give us clues. Luckily, this was an early melanoma once again, and so the patient's absolutely fine. They've had the lesion removed and they've been cured. Other unusual places to get melanomas, as you probably are aware, you can get them under the nails. Typically, it's the big toe or the thumb rather than the smaller nails. And it presents as a multi-shaded line, a bit like a barcode that grows along the length of the nail and slowly gets wider. And you can see at the cuticle there in the skin at the base of the nail, there's a bit of pigment in there, which is a bit of a clue as well to melanoma. And again, these melanomas are pretty bad news, and so we like to see them early and deal with them. Luckily, they're very rare, but they still need to be treated. And I'm sure you're aware of the story of Bob Marley, the reggae singer who died in 1981. He went to his doctor in 1977 with a dark line under his toenail, which they thought was just a bit of bruising from playing soccer. And so it wasn't picked up, and of course it spread and ultimately claimed his life at the age of 36. So another little reminder of how these things can be bad news. So in terms of how you look after your skin, and I guess being golfers and being out in that UV light and perhaps having fair skin, you're at risk for skin cancers. So the things to be looking out for would be ugly ducklings, or things that are changing and looking different, things that are like a sore that just won't heal and it tends to bleed or look like a bit of a scar, things that have got patches of pink on them that aren't really going away, things that are painful or angry or raised and crusty. And if something that it's growing rapidly and it's quite firm and elevated, again, that's something that needs to be assessed pretty urgently. And so, as I said before, the key thing really is sun protection. So wearing a hat, preferably with a brim, putting sunblock on, preferably a broad spectrum sunblock. Although UVB is the most likely cause of skin cancer, because that's the one that affects the top layer of the skin. UVA can be linked with skin cancer. So a broad spectrum sunblock that you can replace every couple of hours because you sweat it off. Wearing long sleeves and trying to stay in the shade as much as you can to protect yourself from the harms of the sun. So essentially it's good to get your skin checked. It's good to get it done with the doctor that knows how to use a dermatoscope. Quite a few GPs around town are upskilling in that. We've had about 20 odd years of experience. One of the first dermoscopy clinics are set up in New Zealand, so we've got quite a bit of experience and background in getting things looked at. But yeah, if in doubt, get things checked out. So that's pretty much it for me. I think Molecheck have, as I say, set up a bit of a relationship with Auckland Golf, and so there's a discount for you if you'd like to get skin checks done. We're very happy to see you and to check things out. And I hope you found that very useful. And thanks for listening. Okay, shall I just hand that back to you now, Jacob?
Yeah, leave it on there, John. Okay. That's wonderful. If you've got any questions, please put them into the chat now. And while we're waiting for anyone to type anything in, if people come to the clinic in Molecheck in Manukau Road there, what's the process for a check then?
Yeah, so essentially it's a bit like a normal doctor's visit. You sit in the waiting room, we call you into the office. We'll have a good chat to you. We put a lot of emphasis on taking a good history in terms of assessing your risk factors, listening to your story about your lifestyle, and obviously your concerns about any lesions that you might have, paying special attention to what medications you take. It isn't just immunosuppressants that can cause skin cancers, but also some blood pressure pills are linked with increased skin cancer risk, and other medications. Then after a chat, then we'll start the process of looking at your skin with a dermatoscope. So you sit in a little stool there. We have a look first of all at your face and through your scalp, and then we get you to pop your shirt off, and we have a look at your hands and your arms and your trunk, and then you put your shirt back on and you lie on the bed. We put a sheet over you, and we look at your tummy and both sides of your legs and the soles of your feet. So it's an all-over check, looking at all the nooks and crannies. We don't normally look at the private parts, but we would ask people to have a look themselves before they come along. We don't normally check the breasts in women unless there's anything they're particularly concerned about. We'll usually take some photographs of things that we may want to monitor. If there's something that's of concern, then we may recommend that it gets removed. Good practice is to be removing about 4 benign lesions to 1 malignant lesion. In other words, if everything you take out is malignant, you could be missing a few things. So if things look a bit suspicious, we'll often say it's best to get it removed just to be on the safe side. It doesn't always come back as being a cancer. People might think, well, why did you do that? And that's partly just trying to be on the safe side. Internationally, best practice is about 4 to 1. In the olden days, when people didn't have dermatoscopy, they'd be taking out between 30 and 100 lesions to get one melanoma. So it certainly is a lot more precise than it used to be. And then we'll send a report back to your GP and make a recommendation on when you should have another check done. For some people that are high risk, it could be once every year. For others that are average risk, it might be every couple of years. And so that's basically how it works. It's pretty low key and not too intimidating. And I guess the message really would be that it's good to get this done because most things that we see are early and easily dealt with rather than advanced things which are less common but a lot more of a problem for people. So I hope that explains things pretty clearly.
And at Molecheck, you do both the checks and the surgery?
Generally speaking, yes, we've got a fully equipped operating theatre and we're all trained. Well, some of us are trained in doing skin cancer surgery. We also contract to the hospital to do skin cancer surgery for them as well. Some things obviously may require referral off to head and neck surgeons or plastic surgeons. But generally speaking, especially if people have got Southern Cross insurance or health cover, we would excise things for them. The cost is pretty much the same as what you'd probably pay at an average GP. It's about $500 or $600 to have a lesion removed, or a bit less just to have a biopsy taken.
Yeah, very good. And we've got a question. What about keratosis?
Yeah, so solid keratoses are a good question. Are a lesion that, or a spot that is a result of chronic sun damage over years. And while most of them just sit there and come and go, occasionally they can grow and become more invasive and eventually become a squamous cell carcinoma. So often, if we see those, and if people wish, we can freeze them off with some liquid nitrogen. We squirt a bit of liquid nitrogen, which boils at about minus 196 degrees Celsius and cause an instant freeze or an instant frostbite of the skin, and therefore kills those abnormal cells. A bit like when you put a bottle of milk on the freezer and it kind of expands and splits. So we also cause the cells to expand and split and kills them. And so we can treat those on the spot with liquid nitrogen, which is another, I guess, benefit of having that done when you come along.
That's wonderful. If there's any other questions, feel free to type them in. Otherwise, it's been very informative. I certainly appreciate your time, Dr. John.
Thank you very much for having me.
Cool. Yeah.
Yes.
And anyone can get in touch with Molecheck with the details there to make a booking. All you need is your golf number, and you will receive a discount from there.